are signers
Right.
of the all-payer model agreement, and
And so that's the focus
so,
of the.
so I think that might be, I'm making an assumption here.
I'm making that.
Can I ask a process question for you? I came in with a list of questions, and I'm not sure where they might get
Oh.
asked. So when we get to the discussion part, will our guests be
We're
with us?
done with the discussion part,
Okay.
that's the problem. We have to be out of here at 11:30, we have two other presentations to make.
Right.
I didn't know that there was, I asked earlier if there were questions around the room.
All right,
So
well,
I don't know
I'll
what to
figure
do.
out how to do it.
Okay,
Because
I'm
I'm not
sorry.
sure where
Well, look,
whether
we're-
I will have my question
In
by the end.
fairness to all of us, we are rushed today. These fine people have made time just before the holiday to
Totally
appear
understand.
here. We don't want to short circuit any of them, and at the same time, just so that everybody is aware of this, we make no decision today. So there will be, theoretically, we have time available, not a lot, but some time available to follow up.
Great.
Vicky does have to go to a commitment, so if you have a specific question for Vicky, you might
The
want
problem is I don't know if it's for Vicky.
Oh, and you have to.
Tracy, in fairness to you, that's exactly right. I have been struggling who to ask.
Yeah,
Right.
and I want to say that I open myself up to a phone call, an email. I'm happy to come back,
Okay.
All right.
do whatever this
Thank you.
committee needs to make sure you have all your questions answered, so.
Thank you very much, Vicki.
Yeah,
I really
thank
appreciate
you.
your
Yeah,
taking the time
thank
here,
you.
as I hope I will remember to say to the other presenters.
I'm sure you will.
Well, I'm not so sure. Thank you again.
Oh,
It's
good,
very
you're
helpful.
welcome. You're very welcome.
Does
And,
everybody have one?
and with that, I'm not sure
He's
we
behind
need
us. Andrew's behind us.
a show off. All right.
You're the first person I've snuck up on it.
Come on in. Joel, might know what to do.
No, thank you so much.
I have like 15 minutes on my
Giving him arms.
So, I don't know, you know
I was
how.
gonna say, what's the difference now?
Immediately.
He's gonna need him in about a half an hour.
Yeah, I'm only allowed to sit down
Just
for a
be
half an
good.
hour at a time, unfortunately, so.
You're spending most of your life standing.
Well, every half an hour I have to get up for 5 or 10 minutes, yeah. I can lay down indefinitely.
I can too, by the way.
Named after my own heart. You get instant sympathy from me with any knee or hip issue. Yours is a hip issue.
Yes,
Not that
yeah.
it's any of our business, but.
No,
Andrew, would you like a glass of water?
Yes, he would.
no, thank you, I'm all set.
Well,
Sure, you can pass them around.
I don't know how long you've been
Not gonna refer to
standing
them.
there. Waiting.
Just a few minutes.
Okay, so
Yeah,
you're
no.
aware that
I don't know if he's gonna
not
use
only
it
are
or
we
not,
under
but
time
because
constraint.
we're already interrupted.
That's all, we're under time.
Yes, I'll be quick, and I would encourage you to interrupt as much as you like
Well,
with your
Vicki made that
questions.
mistake too.
Okay, well, you'll judge that, and as with Vicky, you know, you have, our office is 5 minutes from here, and you have unlimited access to us, so if you need me to come back in person at any time, if you'd like to submit questions in writing, whether you think they're for us or not, you're not sure, go ahead and send them over and we'll do our best with them, and just acknowledge our limitations. Could we just really quickly say
Yes.
names again, just for, because I was on the phone.
Well, I'm Joel Cook, we'll go around the same
You know
sequence.
me, Laura?
Peggy Maxwell.
Peggy, okay.
Martha Bonet.
Yeah,
Tracy Rund.
Tracy, John, pleasure to meet all of you.
And all these other guys,
Yeah,
you know them?
a few of them I know.
All right.
Maybe starting there, just past
I'm
Mike.
Julia Shaw with the Austin Healthcare.
Okay, Julia, I think we've met.
Don Tenney, President of Vermont NEA.
Tim Duggan, State Treasurer's Office.
Michael Clausen, Deputy Treasurer.
Okay, great. Okay,
We'll probably end up doing the same thing we just did, which means that with interruptions, I'll try to stop you at 25 of 11.
okay, great, yeah. And I gave myself some pretty strict notes here to keep from wandering off, which I sometimes do. So,
Oh, bad, we're a bad combination.
what I'd like to talk about today primarily is why I think this is an important opportunity for VEHI and its members right now, and to help you understand why Blue Cross Blue Shield of Vermont, who has been working with One Care Vermont, and the concept of payment reform and delivery system reform for several decades, frankly, thinks this is an important opportunity and why this would be the time for VEHI's members to be a part of this initiative. So those are my major goals. I'll try to just get those 2 points and then I'll fill in as many sort of surrounding details as I can. Before I get into the meat of this, I feel like it's important for me to offer an apology to those of you on the VEHI board in particular and to the VEHI Trust.
That's great. Don't spend too much time
Okay.
on that, because we understand.
I will just say that we, in pursuing this model, we really felt like we had simplified and de-risked moving forward with participation in the all-payer model on behalf of our clients. And as I drew that conclusion, I really misunderstood how complicated this is for all of you, how many stakeholders are a part of this process, and how much communication was necessary. So I grossly under-communicated over the past few months, and I'm sure that the trust administrators could talk more about that. And just sincerely, I apologize. And moving forward, I just want to say it's so important that Blue Cross and VEHI remain working together collaboratively. We have just done amazing things together over the last couple of decades, and that's where I will focus my attention on the future, making the most value from that.
It's only the number 19,000 because of the one care issue, but VEHI oversees insurance administered through the Blues for 43,000 Vermonters.
Yes.
Which is like 6 or 7% of the population, and it's also about almost 25% of Blue Cross Blue Shields. I don't like the term book of business, whatever
Yeah,
you call it.
yeah, it's very significant, yeah. So with that, let me just talk a little bit about my background, also very quickly, just so you know where I'm coming from. I started in this industry with Kaiser Permanente, a fully integrated health system in California, a little bit over 20 years ago, which I can't believe. And I worked for a long time as an underwriter. So really thinking about how the money flows through this system. I then sort of transitioned into the provider network management space, and that's been, the majority of my career, working with providers on rate negotiations, different payment mechanisms, and almost from the beginning of my time in that work, I've been working on payment reform. It was a concept that we put on the table in 2008 and said, what can we be doing differently to shift the incentives in this system? So I have a fair amount of background in thinking about how all of this comes together. And what I would say is I've come to the conclusion over time that payment incentives are a really important part of this system, but I think I've come to think of them more as an enabler or a facilitator than a driver. So payment reform can help us achieve our goals of changing the delivery system. I don't think alone they're sufficient to drive those goals. I think some people are cynical about if we just change payment, will the system really change? Maybe. In a big way, in a lasting way, I don't know. That's sort of hard to say. But what I do feel really positive about asserting is if the system is trying to change, if it says to itself, we can be more efficient on behalf of our members, we can do a better job coordinating care for our patients, we can do a better job communicating with each other, and in some ways payment gets in the way of that, could you help us change payment so that it supports the changes we're trying to accomplish? That to me feels like a really compelling reason to pursue payment incentive change, and I feel like that's where we are. So I guess my first message would be, I look at what's happening with One Care Vermont and the providers who are a part of it, and I see a large number of the caregivers in our state coming together and saying, we really want to throw our time and energy behind building a better healthcare system for our members. And I think we collectively acknowledge that what goes on in the room when the patient is sitting on the table on the butcher paper, I like to think of it, that's a great experience already, right? We're getting, I mean, the numbers tell us we get A+ results from virtually all care providers in Vermont. They do a great job taking care of members or patients when they're in front of those members. We know that that's true, but then we sort of step back and say, well, there's still so many people struggling to be well. There's more readmissions than we would like. There's more emergency room use than we would like. The prevalence of chronic conditions is higher than it feels like it should be, and a lot of people are struggling to manage those chronic conditions. So we have these fabulous caregivers, and we're getting these great experiences at the moment of care. The problem lies elsewhere, right? And I feel very strongly that OneCare is understanding that the problems are in between those visits, right? It's a challenging thing when you sit down with your provider, and I've had a little first-hand experience over the last few weeks. This has all progressed stunningly quickly from the time that we said, let's have an MRI, to the time that I woke up from the anesthesia. There's a huge amount of information flying at you. Resources to sit down with you and talk with you about what's happening, to help you find your next visit, to understand really how to take care of yourself. Those things are hard to come by. They come in photocopied packets, right, that are given to you by people who are well-meaning but in a hurry. And that surgeon, who's phenomenal, has a lot of patients who need his or her attention, right? And is spread really, really thin. And the way our system is currently financed kind of necessitates that way of being. So when I think about what OneCare Vermont understands and how they're trying to intervene, I look at that from the perspective as somebody who has spent, more than a decade in the trenches with providers, haggling with them over money, trying to bring down the cost of care. And I see something really positive here, a focus on the kind of change that our healthcare system really needs. It's different from things that we've tried in the past. The HMO movement, where we really thought if we can control the flow of people through the system, sort of limit access, push the volume up in certain places, we can get sort of this better purchasing deal for everybody. There's a real understanding that we can't just change the system around the providers, that the providers themselves are going to be investing differently in the way they deliver care. Right? So that's sort of the bedrock of why Blue Cross Blue Shield of Vermont has been interested in this movement from the first. So now let me switch gears a little bit and talk about sort of why now. And it may be helpful to just give you a sense of our history. And Vicki, I think, did a good job of talking to you about how the all-payer model got started and where it came from. So I'm going to skip over that and just start with our involvement in it, which goes actually back to 2014. We were the first payer really to be in a serious relationship with OneCare Vermont, even before Medicare. I think we were along with Medicaid, the first working with OneCare on a shared savings basis before the all-payer model was even ready to start officially. We did that because we felt it was the right direction for the state to go in. But I will be honest, in 2014, we looked at OneCare and we said, truthfully, we don't expect a lot to happen here. It's a very small organization. They have few resources. They have a huge amount of paperwork to get through over the next couple of years. Working with government payers is triple, quadruple the overhead of working with us, I think. And the overhead of working with us is not insubstantial, right? We have a lot of contracts that we keep in place to protect our members and to make sure that they are getting the benefits, right, that you all are paying for them. We also looked at OneCare and said, boy, they're going to need some time to build understanding and expertise. So we thought putting our QHP pool, that's our exchange pool, into their model early made a lot of sense because they would be working with Medicaid, and that pool was a lot like Medicaid. The business model with them was structured so that there was no cost to us unless there was value created. There was no upfront admin charge, right, for those members to be in. We only paid in the form of shared savings, and only if OneCare helped us lower the cost of care. So it seemed like a kind of a no-risk deal, and our expectations were relatively low. Even at that time, we talked about what about the commercial large group the insured group or the ASO group, and we had fewer ASO clients at that time. So it was a less meaningful question than it is today.
I just missed something. You used 3 initials just.
Sorry, administrative services only. Self-funded client is an ASO client like VEHI, where we're more of an administrator than an insurer, right? The insurance risk is with you. We looked at that with OneCare very early on, and we said it certainly makes sense to go there someday. We want all of our members to benefit from the change that's coming, but I'll be candid, we didn't think 2014 was the right time to do that. For one thing, there wasn't a lot happening that we could turn to a large client and say, we've got demonstrable value here. That could be okay if it was no cost and no risk, right? It was just, hey, no harm if you're in it, that'll do it. If it does good, great, and if it doesn't do good, no one gets hurt. But at the time, OneCare felt, and I won't try to judge that in retrospective, that they needed a fair amount of administrative funding from commercial large groups to be a part of the model. And we looked at that and said, candidly, this is not the right time for us to do that. We're not prepared to ask our large group clients to pay to participate in this model that hasn't demonstrated results and that is still very small and is still focused largely on contracting and building resources. And we understood why the additional administrative funding from our large clients could be helpful to them. That said, we felt our large group clients already bear a significant burden of funding the healthcare system. I think we're not shy about acknowledging that large group clients pay more for care than Medicare and Medicaid do. We call that the cost shift sometimes under some circumstances, and we didn't feel that it was appropriate for the large group client to take on a larger burden of that cost share. So we agreed with OneCare. We've all got a lot to work on anyway. Let's focus on this QHP model. Let's get the Medicaid and Medicare stuff up and running. Let's try to understand how data will flow and begin working collaboratively to really change the care system. So where we are now, as we expected, not a lot happened with our QHP pool from 2014 to 2017. We looked at the results at the end of each year on the financial side, and they were about what we expected them to be, even if we had not been working with OneCare. They came in right about where they thought they were going to, and that aligned with our expectations because there weren't a lot of major initiatives underway that would influence cost at that point. I will say though, we started to see, even in the early years, some exciting things on the quality side. Some places where quality measures in the pool of members that we attributed to OneCare were definitely moving in the right direction at a quicker pace than those for our members who were not a part of OneCare. And it's hard to establish, statistical significance, right? One of my statistics professor used to say, correlation does not imply causation. But it was definitely, it was definitely promising that we were seeing that movement. In 2018, things changed more dramatically, and that became evident to us very early in 2019 as we started to look back. We did, in fact, see some very statistically significant movement on a couple of key measures that Vicki has already talked about this morning, things that are hard for us to move, that move very dramatically in the OneCare pool, but did not move in the same way in the rest of our book of business. And we've talked to the administrative team about those measures. I'm not going to lay all the detail on you now in the interest of time, but that was very encouraging. And then as we settled sort of financially with OneCare, we came to understand that it was quite likely that they also helped us save money on that pool in 2018. That was a very difficult thing to say, or to show, because they made a payment to us. They paid us back on the shared risk side, but our actuaries went back and analyzed what would the results have been if the Green Mountain Care Board had left our rate target where we thought it should be, which they didn't, as part of that rate review process, they cut it down. Our actuaries said, this rate that they have left us with is underfunding the target. We will underperform. They redid the analysis and said if they had left the target where we wanted it to be, we would have actually shared savings with OneCare. They would have helped us save over $1 million on that pool, which is very modest. It sounds like a lot, but it's a very small number. But still, it would have been great to have been able to share that savings with them. It definitely showed us that things were moving in the right
So what
direction.
was the difference from the actual rate?
Let's see, I think it was about almost $1 million swing in the other direction. So OneCare ended up paying us.
Also not that significant.
Yeah, right, pretty small, but definitely measurable. The other thing that really changed for us in early 2019, and I don't know if these two things go together or if this was just the time, OneCare had a leadership change, as you know, and we also started to see this sort of dramatic recommitment to the clinical transformation, right? I think OneCare may have actually said to us in a meeting, thank you for sticking with us as we worked on building out this organization and getting a lot of this work done. We're ready to shift into performance mode and we really want to work with you. So we built a couple of collaborative teams, the most important of which is the one that puts our chief medical officer, our director of integrated health, and our nurse case managers together with OneCare quality and clinical resources to ask what can we be doing together to improve the value of the care that those people who are both Blue Cross members and OneCare attributed lives are receiving. So I want to just take a moment to hold on to that point and sort of switch to how the system change, this OneCare change impacts our members, your members, right? All the individuals who are a part of this program. Fundamentally, the basics, or not fundamentally, 100% the basics of the benefit plan that you all provide for your members remains unaffected by this change. So members have the same benefits that they've always had. There's no impact on cost share. They have the same access that they've always had. In Vermont, in the region, across the nation, no one will be steering them toward a provider or away from a provider. They make all the choices about how they use their benefits and where they receive care that they have in the past. They will still have the benefit of all the services that they have always received from Blue Cross Blue Shield of Vermont. So our work with OneCare does not in any way turn off any of those support services that your members rely on. Our nurse case managers, our quality managers, our customer service folks, all the people who interact with your members on a daily basis will continue to be available to them, and they will continue to do essentially the same jobs. Our role in supporting the healthcare system is very member-focused. We identify people who are in trouble, and we make one-on-one outreach to those people to try to give them support. OneCare's role, as Vicki talked about, is helping the provider system collectively be better at serving patients as they're moving through the system. The synergy of those two roles is us understanding where we're both sort of touching the same dynamics that can be improved and how we can use our resources together to get a better result for the member, for the health plan, for the clients who are paying for the benefits, right, and trying to support their organizations with the best benefit strategies possible, and for the provider systems. One of the questions that comes up very frequently as we talk about all of this is, don't we already have an access problem in Vermont? I mean, people have trouble finding primary care, they have trouble getting specialty care. All this that you're talking about with the ACO sounds great, but isn't that going to just make the access problem worse? Well, there's a lot of things we could talk about there, but one that really comes to mind for me is if we are making a better care system for providers to work in, we will have an easier time attracting and retaining caregivers in Vermont, and that's a challenging thing now. The other thing that comes to mind is we are creating more resources for these practices, both through the investments that the government payers are making, through the shared savings that we hope the practices will earn as they work on the commercial side, and frankly, just the time and energy that our care managers, our care team, Medicaid's team, the Medicare folks are putting into working with OneCare and the providers on the question of how can we help make this a better healthcare system. So it seems like there's a real potential even to improve access. So the final point then, the other thing that changed in 2019 is that OneCare Vermont told us, you know, we think we're agreeing with you now that the large commercial insured shouldn't pay an admin charge to be a part of this. I mean, we'd still like it, to be honest, if you could get it for us, but we get where you're coming from as far as the cost burden. We're willing to start bringing them into this model on a basis where they only pay retrospectively and only if we've helped them save money and made a better care system for them.
Is that where the number's 21 something dollars
Right,
and 3 1/4?
exactly. Right, so the $21 has gone away. That was an admin charge, and 21 is just an estimate. You know, we never had really negotiated that. It was just something we talked about. And the $325 that's in place now is actually dollars that were redirected from fee-for-service care anyway. So that didn't even require a new investment by any of our clients. It was money we would have paid on a fee-for-service basis. But just now out there as a capitation, right, a value payment that's only available to OneCare members. So essentially, we found in early 2018 that OneCare had agreed financially with us to de-risk this for all of our clients. So this essentially the same terms that allowed us to put the QHP members in back in 2014. If it works, fantastic. If it doesn't work, we're not out any money, and members are not at risk. They lose nothing. They only have the opportunity to experience better care as a result of this. And if we can foster that and help grow it, it seems like a real opportunity for Vermont.
As I've been wrestling with this, there's I don't know if the term is conceptual issue, but it's an issue. And the issue, in my mind, has been, how is it that in a system, OneCare, that is owned by the hospitals, capable, I guess, even of ensuring a sufficient focus on the needs of the primary care system, which is not hospitals.
Yeah. Well, I can't fully answer that question, but I can say that we share the concern, and our approach with working with OneCare and in provider reimbursement generally is to force that issue to the top. So as we manage our fee schedule every year, we focus very heavily on primary care, and those of you who know specialists can attest to this. We have given primary care physicians significantly bigger raises every year than we have to the specialist community. And as we've worked with OneCare, even on the 325 that we sort of shifted to their bucket, we said to them, it is very important that these monies are supporting primary care physicians. We don't just hand it over and say good luck with it. We're pretty involved in how they allocate those dollars, and we think primary care is where it all has to start.
Yeah, that's a good answer from the perspective of the Blues.
Yeah.
Maybe it's unfair to ask you that question, and if time had allowed, maybe in a follow-up we can ask it of OneCare itself.
The other thing I could say is that we contract with hospitals still, as we contract with OneCare, and we hold those negotiations annually. So we don't do 3 or 4 year contracts, they're annual contracts, and we are very aggressive about protecting the interests of our members in those contract negotiations. And we're pretty clear with the hospitals about what's important to us and what it means to be a part of our network. And we don't have as much leverage as we'd like there, right? It's a tight system, but they're responsive, and we hold them accountable, and they're generally, they get it, they value primary care too.
Yeah. I would,
Vicki, one care is an organization of providers, not
Yes.
providers and insurers.
it's an organization of providers, not insurers. And the only other thing, if you wouldn't mind me jumping in a little
Please.
bit, is that we have a 21-member board of managers at OneCare that makes all of our decisions. And we had independent primary care that sit on the board, as well as federally qualified health centers, and primary care that are owned by hospitals too, because remember, there are primary care within hospital systems as well. And if you look at our overall investments, the preponderance of our investments are made in primary care. So whenever we receive funding from insurers, the first place it goes is primary care.
Okay. And I'm sitting around having read whatever I've read, and conventional wisdom, if that's what it is around, is that the plight of primary care has not improved in the 6 or 7 years since OneCare has been around, and in fact, it's gotten a little, I don't know if the word is worse, but more difficult. And if that's all accurate, then it raises a specter of questions around the extent to which nevertheless a hospital-dominant organization can, in fact, provide the focus that we all seem to have an aspiration regarding, and that is keeping people well, keeping them out of the hospital, keeping costs down, and not depriving people of care. That's,
There's an awful lot of factors, a lot of variables out there, that's all I'm gonna say.
It sounds like for VEHI, Blue Cross Blue Shield would be the primary partner in monitoring the accountability of OneCare. Could you just summarize again what those benchmarks that you're looking at for accountability are? And I'd like to hear more about if they're not meeting the benchmarks, what are the options?
Yeah.
What if we decide this isn't working and we need out?
Sure.
If we decide
Yeah.
to go in.
So there's sort of 3 areas of focus there. One would be the cost of care. So there we use actuaries to just determine how the cost of care is trending and what it would be if there were no interventions by OneCare or other provider systems that were trying to make a difference. It would be sort of a do-nothing cost of care. And we monitor that and just sort of statistically validate that we are seeing financial benefit as a result of the participation. The second would be the quality scorecard. We've shared this detail with the administrators, and we can share it with you as well. So I won't go through the measures, but there's a number of measures Vicki talked about. Some of them, these are things that our quality team was already measuring. So and there's a very sophisticated statistical model that's handed down by national organizations for how these measures are defined and measured. And so we use those to see what's going on the quality side. And in fact, we measure a number of quality measures that are part of our overall agreement with OneCare. There are 10 or 12 on our official contracted scorecard, but our quality team will measure 25 or 30. So we'll be watching for other things. It may not be a part of the contract, but it's important to us that all of the quality is monitored. And then the third place we'll be looking for is what I think of as top-line measures or activity indicators, and this has been one of the biggest holdbacks. We need to see activity that says to us, yeah, that can make a difference. I think the bottom line results, the actual cost savings, will come kind of slowly. I think 0.5% or 1% a year would be pretty great. It's a big system, it's complicated, it's gonna take a long time to turn that ship. But I wanna see pilots that are making a difference for our members. I want OneCare to tell us, yes, we're gonna work with you on a reach out to all your members who haven't had a primary care visit in the last 24 months, and you're gonna actually see with us that we've done that action and see the result of that. So we've got a list of, I think, 5 or 6 really exciting sort of clinical collaboratives like that one, that's one of them. And we're gonna be watching to make sure that OneCare is at the table with our team, making them happen. And if we've got those 3 things lined up, that feels like a pretty good set of guardrails to us. You know, the financials, the quality metrics, and then the actual work. the last part of your question, our contract with OneCare is annual. And our negotiations are challenging. And we are still working on our negotiations for the 2020 contract, and we probably will not be done with them before 2020. We don't attribute members until the early part of the new year. So we will evaluate this model every year. And I think we've been clear with OneCare, with the legislature, with the administration. We want to be a part of the right kind of change for Vermont, as all of our employer group do, right? You all do. Everybody we work with wants a better healthcare system for Vermont. But we're only going to continue to participate if the terms benefit our members, and not in the abstract long run, it probably will work out, trust us. Our members pay a lot for the care of this system, a disproportionate share. It has to benefit them in the near term. And if we find a year from now that we're not moving in that direction anymore, the activity has stopped, the financials are going in the wrong way, then we won't continue to participate with this. And also, making this a part of our network, I'm also the sales guy, means that I have to sell this every year, right? So I have 100,000 lives or more tied up with large group clients. I'm answerable to all of those clients. So next September, when they start thinking about renewing their business, I want to be able to say to them, you got a better network with us than with anybody else, because we've worked with OneCare to bring you this value. You simply can't get that anywhere else in the country. And I really believe we're on track to do that. So that's another sort of benchmarking, is our own internal incentive to get it right.
But for the time being, the payment structures, the networks, the things you negotiate, still exist.
Yes.
So if we said, thank you, we enjoyed our time with OneCare,
Yes,
but we're not continuing,
that is right.
it's an administrative switch by Blue Cross Blue Shield,
Yes.
and in either case, the experience of the member on the ground is the same. They still see their primary care provider, get the specialty care
Right.
they need.
Right. We continue to negotiate all of our other provider contracts,
Okay.
frankly, as if the OneCare relationship didn't exist. We won't be able to do that indefinitely, but until we have a proven system for Vermont that we want to really invest in, as this is going to be a 10 or 12-year thing, we will continue to do that.
Quick question, sorry, follow up to that. Edgar, how long will it take to gather the information so that we can be in a place to you can be in a place as Blue Cross Blue Shield, we can as VEHI, make an informed decision about whether we want to continue this for a second year, again, if we chose to.
Yeah, it's a great question. I think by midsummer next year, we're not going to know.
2020?
Yeah,
Okay.
we are not going to know a lot, other than to be able to tell you in much more detail what OneCare is working on behalf of your members. So we should be able to say, these are the programs, these are the number of people we believe are being touched, these are the kinds of changes we're expecting those people to experience, right? These people with this chronic condition will
The
be,
top line measures.
exactly, people with hypertension, with VEHI, we identified a few hundred of them. They're going to be getting sort of home monitoring. We know that happened. We should be able to give you that. I think actual, the quality metrics won't come to us until end of first quarter of 2021. The financials about the same time. And I would say that I think we'll be in this experimental phase for 3 or 4 years. And I would say 3 or 4 years out, we should be to the place where we're really starting to see the financial returns being significant, measurable, repeatable, and growing. And that's the point where we would say, yeah, this is really working. Or if we're still at a quarter point here or there, 3 or 4 years out, I think we would all step back and say, okay, we misunderstood what we thought we were going to accomplish here. This has been nothing, and let's regroup and figure out how we make it something or go on to something different.
One of the things, opinions, I guess, I've read, suggests that there's nothing wrong with an experiment encompassing 160 people that is in any significant way improved by an experiment encompassing 250,000 people.
Yep.
I don't know what the question is.
Yeah, no, I got it. I wouldn't disagree with that. What I would say, and I think I missed this before, another reason I think this is a moment for all of our large clients and our network in particular is that the terms of entry for our clients are as favorable as they can be. It's voluntary, right? Blue Cross is doing this because it feels it's right. We have an arrangement with OneCare that is dialogue, collaborative. I have nobody from government saying thou shalt do this, as we have with other expensive reform initiatives in the past where we've been forced to pay in with no collaborative involvement with those leading to change. To me, there is a grab the bull by the horns when you're strong and the bull is young. I mean, we're fully in control of this thing, right?
If you say so.
I don't know, business metaphor is not my strength.
Might explain what happened to your hip, I don't know.
Yeah. This is definitely the best possible conditions for, like, it's just as a business person who negotiates contracts, I'm looking at what's in front of me on the table and literally saying, everything I asked for is there. This is the deal that I wanted for my clients to be a part of this. Maybe that deal will still be there a year from now. I don't mean to make that as a threat that it won't be, but it's there now and it costs us nothing. So I kind of want to take advantage of it.
So did you ask that it be there for the next 3 to 4 years, since you just said that's probably what it's gonna take for us to figure out if this is?
Well, we did ensure that we're not going to be pressured to go anywhere we don't want to go by OneCare.
Right.
Now, I can't, government does what government does.
Right, that's-
New governor, new legislature, we could be pushed in a very different direction, but that could happen at any time. Hopefully, the precedent of being involved, having a model laid down would offer us some protection even if government was involved in a different way and said, we're forcing you to do this.
So the no cost, no risk to all of our subscribers and our members would be, we should think about that for the 3 to 4 years
Yeah.
it would take for us to figure out if this is worthwhile or not.
If OneCare came back to us,
Here and then
yeah.
popping right back out, because all of a sudden there is a greater risk or there is a cost.
Yeah, if OneCare came next year and said,
Right, but
we'd like that admin after all, if you want to keep participating with us in 2021, I think Vicki would not be surprised at all when I said, yeah, no thanks.
right.
We can't do it under those terms.
Even if it means pulling out.
Yeah, but let's talk about how we can earn you the money through the shared savings, which is our shared goal, right? I'd love to see OneCare get funding that it needs through shared savings, because that means we've all won.
Right.
That's where we want our attention to be.
I was gonna say that, to your point of when's the right time, from the provider's perspective, they have to have the majority of their patients under this model in order for it to feel right for them as well, right? So that they can not have to think, oh, this is fee for service, I can't do this for this particular person, but this life is an attributed life, so I can for this. So their goal is to have as many of their patients in their panel under one common model that allows them to deliver care the way that they want to. So the longer it takes to do that, and it does come at a cost to them to do it, they might have to say, we're just gonna revert back to fee for service. That's not what we wanna do, but we can't have a foot in both canoes and operate 2 business models until we make a decision. I think that's the challenge from our perspective as well.
As a contract negotiator, I buy that.
Yeah.
It really holds water for me.
I don't necessarily disagree with it, but what's magic about 50% plus 1 in that discussion?
I think from the provider's perspective, they want to be able to have one common, they want to get to that one common care model.
Well, that requires 100%.
That does require 100%, and that's the aspirations of the all-payer model, and the longer it takes to get to 100%, the less compelling it feels to the provider network.
Well, I know you need to go,
I
obviously.
do, I'm actually late
Well,
for
that's,
call.
but what I'd like to know is, how do you get to 100%
So,
without forcing people?
so I think how we get to 100% is to show them that this delivery system can can work if you give us some flexibility, like the all-pair model has allowed, to say, we're gonna take a budget, we're gonna convert some of those fee-for-service, and we're gonna guarantee some value out of it, and if we don't, then we're gonna give you the money back.
And the goal is 100% by when?
2022, it's not quite 100%, but
Well,
it's
okay,
darn
that's fair
near
enough.
close,
Fair
but,
enough, yeah.
2022, so,
I certainly expect in 2-3 years, I'll have clients from United and Aetna coming to me saying, we want to be a part of this. We want Blue Cross because you guys have figured this out and no one else has. I mean, I think success is really gonna
Yeah.
motivate a lot of people to wanna be a part of this.
I mean, it's been taking financial responsibility from the providers actually saying, we're gonna take financial responsibility, that's a big commitment.
Thank you.
Yeah, I gotta go, I'm really sorry.
Thank you.
Happy holidays.
Well, happy holidays, everybody.
You too.
Well, New Year.
I have a question not
And-
for today.
and not for today, is that
No,
true? too?
not for today, but I want to put it out there. Sounds to me like Blue Cross.
And it is for today.
I wanna put, well, I wanna be sure that it's on the table for a future
Okay.
answer. It sounds like Blue Cross Blue Shield is primarily responsible for holding OneCare accountable if we if we opt in. So my question is for Blue Cross Blue Shield and our trust administrators, how do we hold Blue Cross Blue Shield accountable? And what's our role, what's VEHI's role in anything with OneCare if we do make that decision?
And I think the quick answer is list out the things that you're worried about and we'll put performance guarantees in your contract that hold us accountable for those results. And if we fail, then we'll pay you back for those failures.
And we have that model in place.
Okay, great.
So it wouldn't be a new model, it'd be an expanding the
I
current.
just want to point out that Blue Cross Blue Shield just suggested that they would pay us back $250 million. You need to qualify.
If we lose $250 million, I don't think we're
I think
we're
we
not.
said first there would be a list of.
Yeah, but then they pay us back. Thank you.
Thank you so
Is that
much.
sufficient?
If that
Andrew,
works for
thank
you,
very
thank
much
you.
for, I really hate what you do.
Oh, no, this is good for me anyway.
Oh,
no.
So many hours of life.
We'll ask you back a number of times.
Thank you. And actually, if you don't mind, I'm gonna hop away to the corner there and stand.
Oh,
and
by
just
all means.
listen to the rest of the presentation.
Hobble wherever you have to.
Thank you.
Thank you again. There, 2 for 2.
I'll just go back.
Oh, sorry.
Land there and sort of camp over.
Happy holidays.
Thank you. Yeah.
All right.
Look, I have kids and adults.
11:30 is approaching and we're pretty much on time. And we can hobble to the corner, you just can't get to the corner.
Thank you.
And I believe, Mike, you are going to make a presentation for us and subject yourself to whatever questions we might have.
Absolutely.
You can identify yourself a little more fully for us.
Mike Fisher, I am the,
John, to get back in the
Oh, I'm
room.
sorry, wait for, we lost a board
I
member.
think we have time
We
to
lost
wait
Bobby
for
Joe
him to
too.
get back in the room.
I was gonna say, you were approaching 11:30?
Well,
Until
Time-
11:30,
differently for
at
you.
which point,
Maybe you have a reputation, Mike.
oh, I know I do. What I meant was that it's before 11:30, and the arrow of time is in that direction, that's all.
Always.
And once we reach 11:30, we will no longer be approaching 11:30, we will be moving in the opposite. Don't twiddle your thumbs for a little while. Want some water, Mike?
Crossing tables.
Oh, yes.
It really is nice.
I can remember when I broke my leg.
Said it went, of course. Never says that.
Again, today, I would have stayed home today, but I'm here. I actually considered Wednesday afternoon, I had a board meeting Wednesday night, which I had to present the first draft of the budget. And so by 3 o'clock Wednesday, I'm going home to do our.
And are you gonna stay till
I just
after?
Yeah.
I'm back, I'm gonna stay home all day yesterday.
Okay, we have
6 o'clock.
more orthopedic issues in this room than we can count.
Oh my God.
I might
So
stay
let's
as
go.
well.
And God knows I really want to, but, all right, we will now resume
I'm not
with our third presenter of the day, Mike Fisher. Take it away.
Thank you. It's good to be here. Again, Mike Fisher, I am, and as I said, I just think it's important for me to do fair disclosure here. I'm a VEHI member. My wife is a middle school guidance counselor at Mount Abe, and
So is he, so is she, so is
Yeah.
everybody except, I think, except me.
And Mark.
Anyway,
Oh, I forgot that part.
So, and then also just to tell you just really briefly, the Healthcare Advocates Office is a consumer-oriented office. We field individual Vermonters' phone calls and help them with access to care issues. Generally around 4,000 cases a year. We have a team of lay advocates supervised by an attorney who support Vermonters who are entering into one part of the healthcare bureaucracy or another. Frustrations with eligibility in Vermont Health Connect, be it for sort of qualified health plan supports or for Medicaid or Medicare programs, or conflicts with their insurance companies or conflicts with their providers. We also have a policy team that represents all Vermonters in front of the regulators and in the legislature. And we're laid out in state statute to do these tasks. And I'll say again, we don't advise employers. If an employer calls us and says, should I do this or should I do that, we don't go there. That's not our role. And I'm seeing this discussion as more of a policy level discussion and I certainly don't have advice today about whether you should or shouldn't join in this effort and have VEHI members become attributed. I think I more have questions and comments and a sense of the lay of the land. And though I'm not at your table as a member, I can't help but put myself at this table and think, gee, what would I want to know? What would be the questions that would be bothering me or that would be important to me? And so a little bit of a discussion about that. I also want to just recognize right up front a tension that I feel with this decision. It's possible that the One Care effort, the all-payer model effort, is good for Vermont healthcare and not particularly good for certain segments of the population. And to put it a little bit more bluntly, it's possible that that there's less deliverables for this effort for VEHI members, but it's still a good thing for the state to do. And I'll be honest that as an advocate for improving the healthcare system, I'd probably be pretty critical of VEHI for not for having too much self-interest in that decision. I commend. We have a whole system to reform, but on the other side, I think it's really important for segments of the population, a group as large as yours, to also hold One Care, and in this case Blue Cross, accountable in this process. It is good for the Vermont healthcare system for VEHI to take care of its members. So that's a tension that I don't know exactly how to rectify, but I just want to name it. And so with that in mind, and then I also want to, the map that Blue Cross that Andrew just passed out is a little bit confusing to me in terms of who is holding risk. A contract with One Care is an agreement to share risk between a payer and through One Care, a provider community. And so I just have to admit that this description of it's costing VEHI nothing, or maybe I think accurately, I think what I understood Blue Cross to say is we would have charged you, I did the math, is it $741,000 more anyway, but now we're doing it through this, we want to apply it through this model. I would want to know much more details about that. When I hear somebody say, hey, this is free, and there's real potential benefits, it just throws up red flags for me. And I don't have real content about that. I'm not at the negotiating table. And I think that's another main point I want to make. I'm in a supremely blind spot here to address this question. I'm not at the negotiating table. I don't know what's being considered for a risk corridor. I don't know, I have a number of questions about how VEHI members will be treated in this agreement. And they go to things like, so I think the conversation that just happened a moment ago is important, and I'll just, your question of how VEHI holds Blue Cross accountable. From my perspective, VEHI, Blue Cross is looking at its book of business and wanting to be responsive to a large member, but you're looking at your VEHI membership. And so I would want to be really careful that you have timely information about quality measures and about cost trends.
Just so you know, the management team has met with Blue Cross's
Yeah.
actuaries and their provider team, and we've had these conversations, so we are not.
Yeah.
We're gonna go past 11:30, we're gonna go to 11:31 now.
So
You have a question?
no, but that's good to hear, I think, that.
Not that we have all the answers that we
Yeah.
need to have, but
Yeah.
that we've had many conversations on those topics.
And so I asked the question of how will the per member per month expenditure for this contract be used for VEHI members? And is it being used in a way that that you feel is the right way to address the needs of the VEHI membership? There's this broad statewide push to get everybody every year into a primary care doctor. It's a good public health push. Is that the right push for VEHI members? I'm not sure. I mean to ask that kind of a question because I think you're looking at a different set of people. And I also want to recognize, I said the word timely. One of our frustrations as we attempt to measure the success and failures of our healthcare system is the tremendous lag in time such that we have to make decisions about the next year before we have the information about the last. In fact, sometimes we have to make decisions about the following year before we have information about even 2 years ago.
Safe to say we're familiar with the dynamic.
Joel asked me a moment ago whether I thought it was useful for us for our comments to the Green Mountain Care Board in anticipation of their decision yesterday to be handed out.
We have them.
That's a public document. I'm happy to have that handed out. I think there's a few things, I'm going to go back up to the high level for a second. There's a few things that that my team called out that we don't feel was addressed in the Green Mountain Care Board's order yesterday.
When you say, what is that order yesterday? We don't know.
Green Mountain Care Board made a decision. Do I have my days right? Was it 2 days ago?
It was 2 days ago, that's nevertheless.
Yeah. A lot of what they called for was come back with more information because of this timing problem, because contracts are still being negotiated. And a lot of the questions they asked for are important questions that we support. There's a few things that they did that I just want to call your attention to, because I think it bears some influence on, it relates to the decision you have. We felt critical of OneCare and in the Green Mountain Care Board's order about how much spending to do on population health efforts. We felt that that the growth of the population should relate to a growth in the spending, that the rate of spending should be the same. And that's not what came to be. We're now down, we lost about a percentage of spending, so we're down to about 3% of the OneCare budget going towards population health efforts. I am really afraid that the level of spending and investment, I also support increased investment in population health efforts. I'm afraid that the level of spending and investment in this is not sufficient to change the culture of this system.
Can I ask, what is a population health effort?
It's a good question. It's a buzzword, and it troubles me because I really wish it said public health. I just like the term better. But it is additional efforts, innovations to attempt, generally to attempt to get people more upfront care. Good stuff.
To get more upfront care.
Good, yes.
So they've reduced the percentage of their budget directed at the theme of moving people in the direction of primary care. Is that too much of a statement?
That's too broad a statement because it includes SASH, I guess you could call this primary care, and it includes Blueprint and multiple other efforts.
Efforts to keep people out of the hospital, is that right?
Generally.
It addresses some social determinants too.
Yeah.
I'd be interested in thinking.
Like what, poverty? We're talking about social issues in addition to.
Hunger.
Okay, all right.
VEHI may be unique in that we have our own, and Blue Cross Blue Shield doesn't provide a wellness initiative that, excuse me, promotes folks getting healthcare, annual preventative care, healthcare, dental care, but you know.
Yes.
And so I'll be interested to think through that as part of the interface.
The other thing that I'm critical of the board's order yesterday was a measure of savings versus administrative expenses. It's something that's been in the order for a while, and the order, I'm going to read the first half of the order. Administrative expenses must be less than savings. Goes on quite a bit longer. But if it stopped there, I would be worried because savings is a measure of expenses versus projected expenses. And in this world of coding and there's a great deal of room for affecting those numbers. I'm trying to put it as gently as I can. So I would be worried that we would get a real measure of administrative expenses versus savings if the sentence stopped there. But the sentence goes on, including an estimate of cost avoidance and the value of improved health projected to be generated.
Oh, good luck.
Projected cost avoidance and projected value of improved health. We will never have a true measure of value of savings versus administrative costs here. And so that's high level. Coming back down to low level, I think that it's a little bit hard for me to understand how to say what is the value versus the expense if it's being told to you that is free. But you do have this concept of a 741,000, and I would ask that you. I'll note that my understanding, and I could be wrong, but my understanding is that the qualified health, that Blue Cross's experience in the qualified health plans last year, it netted a 0.3% savings, I think. I can't remember, 0.3, it's something like that. And when we asked whether that included a recognition of the administrative expense, they said no. And my recollection is that when you included the administrative expense, there wasn't a savings. And I don't know how to pull apart. I listened to Blue Cross's presentation a moment ago about how if the board had given more money to Blue Cross than they did give, there would have been more money for Blue Cross to have been able to share with OneCare. It's hard for me to pull all of that apart, but I sit here from the consumer's perspective, thinking, wow, if the board had let them charge me more, they would have had more money to share with.
We would have paid them more upfront than they would have had to spend, and they could call it savings.
And I'll just recognize that we, you know, I'm in this role where I'm predictably, what comes out of my mouth is pretty predictable. We go to the Green Mountain Care Board every year when Blue Cross and other carriers say they want a rate increase and say it's too much, people can't afford it, it should be less. And then we fight about it for a while. So,
But I have a question related to that, if I can ask you. So, I understand your point about, you know, one care might be good for everybody in the big picture, and it might be better for targeted portions of everybody, and maybe it's not as good for VEHI. However, then that conflicts at some level with VEHI's responsibility to try to improve a system that clearly, if it's not improved, I can't even guess what's gonna happen. So, you know, is VEHI taking care of its members if we have increases of 13% in your eyes? And should we just continue doing that, or what should we do? Because to me, we can call OneCare an experiment, but, you know, that's what other options are there?
yeah, no, I think there's a fair point behind your question. I agree. We are in this together. We have one healthcare system, and we're all in these little segmented pools about how we're paying into it, but ultimately it survives or doesn't survive for all of us.
And I guess extending that, I would say, being the head of a school system and taking the heat as a head of a school system for what a lot of people will say is the failure of education. What in government, what in society is operating effectively right now if we're judging the OneCare effort is not operating effectively? I hear a lot of, here's things that need to improve,
Yeah. Well,
but what are we measuring it against?
let me say, my intent here is to raise concerns, not to say that I disagree with the effort. I agree with the effort. The current healthcare system hurts people. The status quo is not something to defend, and the current cost and the rate of growth of the cost is unsustainable for all of us. I see my role here is I'm accused of being impatient.
That's your job.
By regulators and whatnot. I am impatient. You know, when I consider how much did I saw the news article, how much did VEHI rates go up this year? 13%, a double-digit increase. You know, maybe we can get a quarter of a point or a half a point off of next year's increase. And I look at, and I have not done this analysis for VEHI, but I look at the impact of high deductible plans and affordability challenges that Vermonters face. The Vermont Health Insurance Survey, Household Health Insurance Survey that was in the field in 2014 measured Vermonters at 27% of Vermonters in the commercial market were underinsured. In 2014, it was 27%. In 2018, it was 40%.
What is uninsured, underinsured?
Underinsured, it's more complicated than this, but on the most simple level, it is a deductible.
Can't out of pocket.
Deductible that's over 5% of income.
Oh, okay.
And so, you know, linking back to the calls we get every day, we hear from Vermonters who say, man, I struggle and I get help in order to be able to pay for my premiums, and I still can't, I'm afraid to go to the doctor. And so, it's not just a VEHI issue, it's a broader issue. Coming back, you know, I want to try and keep coming back to the decisions at this table. I don't see how the decision to or not to join OneCare affects that. Certainly in the short term, maybe theoretically years out, but it's hard for me to see it. But I agree with you also that people, in this world, people say you're either with us or against us. And in my attempts to express concerns about the actions, because I want it to work, people evaluate me as an opponent of OneCare, an opponent of the all-payer model. No matter what I say, people see me in that light, and I don't mean that.
So I want to make sure I have in my head the areas that you suggest that we're very thoughtful about as we consider what is perhaps the only alternative to status quo. And that's spending on total population health efforts, not only maintaining a steady percentage of growth in that with other growth areas, but also making sure that the basic investment in that is increased to something closer to something we might agree on as adequate.
If I could jump in,
Yeah.
I think I might be asking you to do an impossible thing, but I think I might be suggesting that it's important for you to hold in your head both what's good for the system and what's good for VEHI members. And so on population health investments, I think it's important for you, I would be curious how our population health investments targeted at the needs of VEHI members.
Okay, hard, yeah, especially.
This is what's so hard about being part of a civilization. We don't get to make that damn decision. We get to influence it in only the most indirect ways, and that's by, I guess in this context, because we have never advocated directly to the Green Mountain Care Board, working with Blue Cross Blue Shield to make sure that it advocates at the OneCare level for that, and hope that OneCare actually moves in that direction and prevails on the Green Mountain Care Board.
But
The
I
only
think
thing
I
that an
think answering the
organization
question impacts the practice.
Yeah, well,
impacts what?
it also means.
No, sorry, impact what?
Impacts the activity.
Yeah. It also means we could think about how we use our own wellness efforts differently. I mean, OneCare is doing something that, you know, if there's overlap
I think we'll find that
Yeah.
the connection is tenuous at
Yeah.
best there.
So that makes a fourth thing, and I just want to make sure I've got the list, that that monitoring savings versus administrative expense, especially as, I think I experienced this in my own area of administration, savings are measured against projected or estimated expenses that don't actually incur because you made the change. So how do you balance staying really close to?
We pay people $500 an hour to sprinkle actuarial pixie dust over something and say this.
So speaking of which, there were a couple of issues associated with transparency of the manner in which OneCare operates, and I didn't get a chance. Maybe if this feels unfair to OneCare because Vicky was here and she's not, I apologize, but the question is, there is a public issue about the extent to which OneCare is operating with sufficient transparency, given that virtually all of its money comes from us all. Do you have a way of commenting without incriminating yourself?
I don't know how much trouble I get in every, who knows how much trouble I'm getting in.
How much more trouble can you get in?
I think that we had a very challenging time getting good information from OneCare in this budget process this year. Part of the reason for that is the structure that Vicki alluded to. In the middle of negotiations, we're trying to evaluate their budget. We want to know the details, actually not of the negotiations, but of the contract. So part of it is that dynamic. Part of it is, I think, maybe I'll just say that we did ask a number of questions about details of assumptions and analysis about how they came up with rates that they didn't feel they could answer.
They didn't think they could answer?
Yeah, or that
They didn't, they wouldn't answer.
that they said that this has implications for the contracts we're in negotiations on, and
I see.
I was wondering if our structure being different from state Medicaid structure changes that dynamic in any way, and that we would be holding Blue Cross Blue Shield accountable, and Blue Cross Blue Shield has that information. I just was wondering, because I saw the transparency thing, like, how are
So-
we different, how are we the same?
Thank you for saying that, because I'm not sure I said this as clearly as I meant to say it. You provide an opportunity for a new data point. Various ones of us who are out there trying to evaluate the whole thing have frustrations with getting good data and believing that we'll have enough information to evaluate it before we have to do another one, honestly. But you, with your relative size and buying power, have an opportunity to ask these kinds of questions and to get this kind of data out to see. Look, the theory's great. The theory of we're gonna change the way we pay providers, we're gonna support, I like what Andrew just said, we're gonna support providers who are trying to do the change already themselves. But I also know that big systems fund themselves very well, and despite expressions of interest in change, sometimes that change doesn't happen. And so I don't know that this is going to work. And I would welcome any additional data points.
Yeah, you know, I've been part of systems that are dependent entirely on government funding. In the early portions of my career, not with Vermont MA. We, who, in that context, had no right to withhold financial information.
Yeah.
And that's, you know, if there's one thing that's nagging at me more than, almost as much as sort of the general policy issues, which I just haven't been able to resolve, it's not the implicit, it's the explicit resistance of OneCare to public scrutiny of its finances. I don't understand it. I mean, I understand that one can come back and say that has implications for negotiations of contracts. I don't know what that means, I mean, other than they're involved in the negotiating contracts, as is most any other large organization.
So let me add another one to the sort of VEHI question. We measure this population, we measure it by payer, and it may be something that you have an interest in this table, and that is that the population is broken down into a scoring of high, very high, moderate, low risk. And there's an intervention plan for those in high and very high. And I would think that it would be interesting, and for those in those two highest risk groups, there's a different kind of intervention, you know, a shared care planned intervention, intensive case management. I can't remember exactly what. I wonder how many VEHI members will be in those categories, and how many will get those kinds of intensive interventions.
But that doesn't address the question of, you know, something as simple as how much are OneCare staff being paid, right? And that's not forthcoming. If you don't want to respond, just say,
I think it's forthcoming. I think we know what people, I mean, we know that their over budget is 20-ish million, and that their salaries are 11-ish million for 77, I think, is the number of employees. And I don't know, there's been a lot of stuff in the airwaves, some of which I would attach myself to and some of it I wouldn't. People get paid way too much in this world of healthcare.
yes.
If I compare the executive salaries at OneCare to the executive salaries at hospitals, they look pretty moderately paid.
All right, I'll let it go, I don't want to.
But, and it costs to do this. We shouldn't hide from it. It costs to do an effort like this. I just want to measure it against the value. That's my only point. I also, just since you kind of, or maybe I started down the track, lots of people in the public have been saying, look, they lost $1.5 million on Medicaid last full year, 2018. Or look, they, you know, they point to ups and downs in the trend. And look, this is a big, being up or down $1.5 million or $3 million is could be just bad projection and no effort. We don't know what it means. I'm not going to get get upset about these kinds of ups and downs. We need to see trend. And but I think the other point that's been made publicly is it's not free. We're spending money doing it, and if that bears out to bend the cost curve and to improve quality, hey, I'm a champion.
John, yeah.
Well, just going back to something, I mean, a lot of discussion today, but, so we're talking about an aspirational pool of 250,000
For this,
For 2020.
that's
for
going
2020. And we're talking about, I'm gonna round it off, 20,000 VEHI members. So that's about 8%. If that doesn't provide some leverage for discussion, and the leverage comes from VEHI through Blue Cross Blue Shield to OneCare about what should the goals be, what is important, how do the interests of VEHI members get reflected in the goals of the larger system. I mean, you know, I realize it's not 30%, but 8% is pretty significant.
It's more than 20% of the projected increase for 1 year.
Right.
I also, just because it was talked about earlier, my team was able to find in the OneCare budget document the communities that are not doing commercial, and those are St. Johnsbury, Rutland, Randolph, and Morrisville. There are 4 hospital service areas that are not doing commercial. And
What does that mean?
They're only,
They're doing
that means
Medicare,
your
Medicaid.
members who live in those
can't go to
communities
those hospitals.
won't be
No, they aren't attributed.
won't be attributed.
Oh, of course, okay.
I mean, it's more complicated than that because, I mean,
Would you say the list again?
Morrisville,
St.
Randolph, Rutland, and St. Johnsbury are Medicaid only.
So Gifford, Copley, Rutland Regional, and I don't know who's in St. Jude.
So,
NVRH.
What?
North, NVRH.
and this is according to the OneCare's budget document. So, and Vicki is right that the other group, larger group of hospitals are either all 3 Medicaid, Medicare, and commercial, or Medicaid and commercial.
The inference here is that if we go down this path, we either do it now or later, and the implicit suggestion is that we seek to attach some sorts of conditions, may not be the right word, but it's probably the right
Goals
word,
or whatever.
provisos.
Accountability.
Performance measures.
Is that fair to say?
It is interesting, you have 43,000 lives, 6 or 7 of them are retired, so they're not part of this group, and that there's 19.
Actually, I was speaking for Michael Clausen, the non-Medicare portion
Right.
of that group is part of this.
But not through this action. They're already attributed because.
No,
they're
the
not-
non-Medicare eligible
Non-Medicare.
retirees
The
would be
Medicare.
attributed.
I make that.
They're
same-
part of that
It's
19,000.
only about 1,000 non-Medicare retirees.
Okay.
Most of the retirees are Medicare and are already in a bucket, but
Now I-
they're-
now I
they have,
understand.
some of their population goes where the actives
I
go.
make that same
Yeah.
mistake all the time.
So what that says, now I can't do the math, but there's 19,000 or so of the
43.
43 who have been who have been attributed through the attribution model to, but which means that they go to a primary care doc who participates. And, and I'll use myself as an example. I'm really curious about whether I'll be attributed. Because if you look back at the last year, the majority of my primary care might be at a participating doctor, or might be because I switched docs.
It'll go by your PCP on January 1, I believe. Whoever your PCP of record is on January 1, 2020, assuming we go in, you're attributed, you stay for the year, even if you change PCPs. It's a
So that's a
one-year attribution.
Different attribution model than I'm familiar with. Usually we say, well, you get the majority of your care in the last year, or last 2 years with a weighted average to.
That's not my understanding, but.
Yeah.
Okay, well, it's a question though, in any event.
So,
It has an answer.
sorry, we're getting way too into it.
Well,
I also am always available to come back to the group or to answer questions individually to any member, and I also have a team that is smarter than me.
you're the team today. Mike, thank you very much. Are there any other questions for the moment? It's 11:15, and Andrew, you've been, Andrew, yes, sir.
I just, one clarification I wanted to offer, just because it sounded kind of murky when Mike was relating it, and we shouldn't get too deep into the back and forth about QHP rating, but on this point of, did we experience savings or not in 2018, I'm not really talking about the premium, though the premium is directly tied to this. What I'm talking about is the projected cost of care. And if you allow me to just round the numbers so you'll get a sense of it, let's say our actuary said in 2018, you're going to spend $100 million on the QHP pool, 60 million on the non-one care, and 40 million on the one care. Green Mountain Care Board said, actually, we don't agree with that. We think the trend is lower. We don't think utilization is going to be where you think it is. We'll say you're only going to spend 98 million. And then that's how rates then get built. So it's very similar to the way you manage the trust. Well, our actuaries looked back at this after the year was over and said essentially, well, we spent about the 60 million we thought we were going on the non-one care stuff, but we only spent 38.8, trying to round that number right, on the one care stuff. We actually saw a savings just on that part of the book. So the question isn't one of if we had more money, we would have paid them more. The question is really, we argue with the Green Mountain Care Board every year about what we think the cost of care is going to be. Our rationale is actuarial, it's just math. The Green Mountain Care Board factors a lot of other things into the equation besides just the math, the biggest of which is the affordability of our projections. But our actuaries look back at our projections and say, those are pretty darn good, and if the Green Mountain Care Board had just accepted them, we would be able to say that we owe one care money instead of one care owing us money. So in fact, one care sort of helped cross-subsidize the QHP pool. Now, of course, all the money goes back to the providers, and it's quite a circle of life there. But just wanted to be clear on that point, because it almost sounded like maybe I had communicated it so poorly that you were thinking I was misrepresenting something, and I didn't want you to have that. Okay, good.
Thank you.
Thanks.
At all. Thank you.
Thank you, everyone.
Mike, thank you very much. We have another item of business. Feel free to stay for the remaining 12 minutes of our board life in 2019, but also feel free to depart if you'd like, and have a wonderful holiday, those of you who are departing, and even those of you who are staying. The remaining portion of our meeting consists of a report by our management team on its recent meeting with Don George, who is, most people know, who is the CEO of Blue Cross Blue Shield Vermont, and I presume Andrew's boss.
And I think to give you more time to talk, I think you've seen the letter. I don't think we have anything to add other than the letter. We had the meeting with Dawn, the letter represents what he told us. I just think we want the minutes to reflect that what's changed since the last meeting is that Blue Cross has made this an opt-in as opposed to an opt-out. When we talked to you in November, the thought was that we were going to be going into one care unless the board took action to opt out before the end of January. It's now your discretion when to opt in and what the timing is. My understanding is still that if you don't opt in by the end of January, when you do opt in during the year, means you may not be able to get the whole year of savings in that model. It may not be able to go retro back to January, but you still have the total discretion on opting in. So I think that's all we wanted to make sure you knew, and sort of the people watching us and reading our minutes know as well.
So is it your sense, folks, that what has changed is that Blue Cross is sort of permitting us to make the decision, or that we have the right to make the decision?
They're permitting us to make the decision.
I would fit it differently. I think it is our right. That is our right to make the decision.
Let's find another wording, Laura, because I don't think the wording presented it is the way Don presented it in the letter. Why don't we just refer people to the letter and engage in a lot of discussion here. Poor Andrew was stuck reading our contract, and that's what led to this issue in the first instance.
I think the letter says it needs to be able to opt in and needs the time to
Yes,
complete the
that's
process.
what we should say.
That was
It
those
doesn't
John's.
reflect a change, it reflects the status of our relationship with Blue Cross Blue Shield Vermont. Regardless of all the Sturm and Drang, whatever that term is, that occurred earlier, and that which Andrew mentioned at the beginning of this presentation. Okay?
Well,
We have
I
like
think,
9 minutes.
I just wanna say, I think that's an opinion, and I don't think we've fully explored that, and I don't think it matters.
That's the point. So we don't characterize it. That's my point.
Okay,
All
I
right,
agree with that.
With 9 minutes left, what shall we discuss?
I have a burning question.
Well, then, I think that's gonna take priority.
Thank you. That I don't, another one I don't expect to get answered today, but I think, I'm hoping that we can have an answer for the next, maybe January 15th, but trust administrators can tell us what's reasonable. That just kind of creates the context for continuing to reflect on this opportunity. And that is, how does the statewide healthcare decision affect our rate setting for the current year? Are they enough? Are they too much? Are they too little? And what do we do about whatever we find? Is it possible to know that by January 15th?
Forgive me, the question is, how does this discussion, this decision be
No,
made?
no.
The statewide health.
Statewide.
Oh, I'm sorry, I was in this
Negotiated
context
Yeah.
and not
Well,
that.
for me, it's
I
important.
understand it, I understand.
It's important context for this discussion.
Understood.
To know
I
if
do, I just didn't understand. it.
13% wasn't enough.
Right.
I don't think we're gonna have the answer by January
No, we won't.
15th,
Oh,
but
okay.
we started to, we've raised the issue with
So
Blue
you're,
Cross.
you're stuck in your own budget process, I understand now. I'm sorry.
We may be able to give you we'll be able to give you an update on January 15th on the issue, but we won't have a calculation.
Okay, so at a subsequent meeting, anyway.
So,
Thank you.
Yes, that's gonna be important.
there's also an issue, and it affects four of us. I forget, Tracy, if you made it, it's about the potential need to change the January 15th meeting.
I'm good.
You good?
Unless,
Never mind,
yeah,
we're all set.
Thank you.
I didn't, I was somehow didn't get
and in
caught up.
fact, it'd be scary to, because I don't know what my availability is a whole bunch of
Other
other
than
times
that.
now.
And Tracy's was a jury,
I got
jury
selected for
pool
the jury.
problem.
Oh, really? Oh.
Okay, so never mind that, so we'll see each other on January 15th where this discussion will continue. Is there any other discussion? We can have 5 minutes of discussion of what we just heard. The suggestion from one or more of the presenters was to ask them questions that we might have. I don't know that we can, want to spend 5 minutes generating them or generating some of them, maybe not. Or do we want to just leave? Happy New Year, Merry Christmas, Happy Hanukkah, Kwanzaa, et cetera.
We talked about a recognition.
I personally would like to hear from trust administrators next time about the ideas that we discussed for the benchmarks and the deliverables and accountability for Blue Cross Blue Shield and how that might play out.
You mean the now or later issue and what conditions to attach to?
Right, and the criteria, the areas that Mike said we might want to consider paying attention to, and how, just with all of this information, how might we structure that if we choose to go forward with the opportunity?
Is that well understood?
It's as specific as I can get.
Tracy, I gotta say, except for, some of those terms, I got it, and I like it.
Are we anticipating that on January 15th, we will look to make a decision on this issue?
I don't know the answer to that. I certainly think that we are going to have a further assessment internally of how we're proceeding. I guess the agenda would say tentative.
Okay, but it would be a goal
Yes.
if we feel like we have everything we need to come
I
to a
don't think
decision.
any of us should be anxious to keep this dragging out. I think we owe it to our people, we owe it to Blue Cross Blue Shield, Vermont, and as Mike suggests, we might even owe it in some small measure to the populace generally to get on with this. Okay, that sound about right? I understand that, Martha, you are retiring not from life or your job, but from this board. And I don't know that that means you won't be attending meetings regularly. But on the off chance that it does, I want to take this opportunity to thank you for the 75 years of service you
Thank you.
provided.
It is always
Thank you.
You've been here since 2015.
Yeah. Been here for a while.
Yeah.
How many, 7? 8? 7
Well,
or
it's
8?
2013 when we changed the
7.
board, she came
Yeah.
in.
That's right. This
Tracy
is the
did
7th
too.
year. Good. Well, thank you on behalf of 43, at least 43,000 of your peers and their families for your service over these years. And I hope things go well for you back home. And I understand you weren't on, there's too much dwelling on health in this room.
Yeah.
You were sick this week, and I'm sorry.
Yes.
Use your health.
Yes.
Is there a motion? Is there
I
a
just like to
motion?
express appreciation to the folks who came, not just the ones that were
Yes,
up here
exactly.
presenting, but other folks who came just to be kind of part of it.
Even you, sir. Absolutely, thank you for that.
Yeah.
And everybody have a great holiday.
Thank you.
And is there a motion to adjourn?
So moved.
All in favor?
Aye.
Any foolish person opposed? Feel free to stay. So, thank you.
I was actually a Kaiser
Oh, yeah?
patient back in the late 90s.
Yeah, where were you?
I worked for the Berkeley Unified School District.
Oh, great. Yeah.
I think Oakland was where I got my
Yes.
service.
Wonderful, I lived in Hayward.
You did, yeah.
Yeah, I think the art and then.
Yeah.
Another
In fact, I
folder,
was
was
just
there
out
any
there
extra
2
folders?
weeks ago, 3
Out
weeks
one of
ago.
the
No,
For a
not that
conference in
December.
San Francisco and.
Here, everything in it looks very
It's I lived in San Fran.
Hey, Sarah,
Totally
I
one way.
moved over to Berkeley and lived there.
You know what,
for
I'll
5
take
years.
this
Berkeley,
with
you know,
whoever
that
replaces
back and
you.
forth, but,
And I'll
Got
keep
that
that
one.
for you.
it's a whole different world.
Yeah.
You know, my
Do
son's
you have any
in
more
get out.
costs made up?
Well, even on Blue Cross, it's down there with Unreal, and they're paying $600 a night. So I found an Airbnb in Hayward, about 5 minutes from the bar station, and I took my old commute in, and it has not changed.
No.
Just that corridor between Hayward and Oakland.
Bar doesn't change much.
No, not at all.
Might
Another,
put that cost
stop,
handout in that
going
folder.